So hello and welcome to this medical emergency podcast on hyperkalemia. During this podcast, I'm going to look at the definition and classification of hyperkalemia, the most important causes to be aware of, the clinical features, and lastly, the practical management of this important emergency. First of all, it's important to mention that hyperkalemia is one of the most common electrolytic emergencies and something that you will most probably be confronted with from the very beginning of your medical practice. It is therefore worth getting to grips with this now, rather than at 4 a.m. on call for the wards. So first of all, let's start out by talking about the classification of hyperkalemia. You can basically classify hyperkalemia as either mild or severe, and this is based upon the absolute level of potassium in the blood. First of all, remember that normal potassium is usually maintained between 3.5 and 5 millimoles per litre. Mild hyperkalemia is a potassium between 5 and 6, while severe hyperkalemia is a potassium greater than 6.5, or a potassium at a lower level but with characteristic electrocardiogram changes. So when thinking about the causes of hyperkalemia, it is important to have just a couple of the most common causes memorized. Here, the most important two causes are renal failure, usually secondary to reduced renal perfusion, such as in severe volume depletion, and drugs, for example, ACE inhibitors and spironolactone. Otherwise, you should divide up the causes of hyperkalemia into those caused by increased release or ingestion of potassium and those caused by reduced renal excretion. Under potassium release as a cause, you can have cellular shifts, such as those that occur in acidosis, or you can have cellular destruction, such as hemolysis, the use of cytotoxic drugs, and rhabdomyolysis. Under potassium retention or reduced excretion as a cause, you can of course have renal failure or reduced levels of mineralocorticoids, such as occurs in Addison's disease, or with the use of ACE inhibitors or spironolactone. Lastly, the class of drug known as potassium-retaining diuretics, for example amiloride, also can cause hyperkalemia. Renal failure is probably the most important cause of hyperkalemia and can of course be divided into pre-renal, renal, and post-renal. The most common cause is pre-renal, secondary to underperfusion of the kidneys, and this usually occurs in hypovolemia, say secondary to dehydration or bleeding. When you see a hyperkalemia, your eyes should therefore naturally be making their way straight over to the urea and electrolytes to look for any elevation. In addition, you should consider performing a venous or arterial gas to detect acidosis that also often accompanies renal failure. So now let's move on to the most important clinical features. Hyperkalemia is usually asymptomatic, and the main worry is the development of arrhythmias, which can unfortunately be fatal. The important ECG changes in hyperkalemia are tall peaked T waves, PR interval prolongation, prolonged QT segments, and eventually the formation of a sine-like wave pattern which, if not treated, will result in the development of a ventricular tachyarrhythmia, such as VF or VT. This is particularly a problem when hyperkalemia is accompanied by acidosis. Other clinical features that can be seen include weakness and flaccid paralysis, however these are really quite rare. So, finally in this podcast, let's consider the practical management of hyperkalemia. In mild hyperkalemia, that is a potassium between 5 and 6 with no accompanying ECG changes, it is enough to simply continue monitoring the potassium, stop any drugs that may be contributing, such as ACE inhibitors or spironolactone, and reduce intravenous potassium supplementation. However, in severe hyperkalemia, where if you remember the potassium is either greater than 6.5 or there are characteristic hyperkalemic ECG changes, it is important to do some specific things. Firstly, repeat the sample, as often the elevated potassium is due to hemolyzed blood that has been left too long prior to analysis. After doing this, it is important to check the urea and electrolytes because if you remember, the primary cause, or the most common cause of hyperkalemia, is renal failure. It is obviously also important to do an ECG and a blood gas. So having done a few practical things first, you should then give some important drugs. Primarily, you want to protect the myocardium from the potassium, and this is done using IV calcium gluconate, usually 10 ml of 10% solution, given over around 2 minutes. Note also, when giving this drug, that the patient should be on cardiac monitoring. You then want to give a drug to drive the potassium back into the cells. The most common regime used is 10 units of actrapid insulin and 50 ml or 50% glucose IV, typically given over around 30 minutes. You might also want to consider using calcium resonium, which can be given either rectally or orally. When giving calcium resonium, however, it is also important to give a laxative, as this drug causes very severe constipation, and patients have even developed small bowel obstruction from its prolonged use. You might want to also consider giving a couple of milligrams, say 2.5 milligrams of salbutamol, as this will also help drive potassium into the cells. This is easy and generally safe to do on the ward. Finally, if it is not possible to lower the potassium to safe levels using these techniques, renal hemofiltration may be necessary, and this should be discussed with the intensive care unit. So that completes really what I wanted to say about the management of hyperkalemia. In summary, hyperkalemia is an important, if not the most important, electrolyte emergency, as it can result in ventricular arrhythmias and death. It is also something that you will come into contact very early on as a junior doctor. Remember that if the potassium is greater than 6.5 or there are hyperkalemic ECG changes, it is necessary to act quickly to protect the patient. In this situation, it's important to stabilize the myocardium with IV calcium gluconate, to drive the potassium into the cells with insulin accompanied with 50% dextrose, and also to bind potassium using a calcium binding resin such as calcium resonium. Finally, if all of these things fail, it is necessary for your patient to go to ITU for some hemofiltration. So that completes this podcast. I hope that you found it useful. Thanks for listening, and see you all soon.